the CAR T cell approach in the solid tumor. For metastatic colorectal cancer, the GCC19 CAR T cell shows some very provocative results. Although it's only phase one, it does show a 50% overall response rate with meaningful improvement of the
Recording
overall
in
survival
progress.
up to 26 months compared with a lower dose. So this is a curve. The one on the left-hand side shows the progression-free survival curve compared with two different dose levels. The yellow one represents the lower dose. The green one represents the higher dose. You can see the progression-free survival is better with the higher dose. The one on the right-hand side shows the overall survival. With the higher dose, it's up to 26 months versus 13 months with the lower dose. This is a study using the Claudin 18.2 as a target for the CAR T cell, especially in the advanced gastric and the G junction malignancy. This is the first randomized trial of CAR T in solid tumor, randomizing 100 patients in the CAR T cell therapy arm and around 52 patients in the traditional control arm using the physician's choice. You can see on this progression-free survival curve, the blue curve represents the traditional chemotherapy arm. The red curve is the cell therapy arm. They improved the progression-free survival from 1.77 months to 3.25 months with a p-value less than 0.0001. This is an overall survival curve. You can tell the cell therapy arm improved the overall survival from 5.5 months to almost 8 months with a significant p-value. So this is the first randomized CAR T cell trial in solid tumor. In ASCO 2024, there was another phase one trial using the GPC3 as a specific target in advanced hepatocellular carcinoma. This is a so-called armored autologous CAR T cell therapy with a negative TGFR beta receptor 2. So it can protect the cells from the negative immunosuppression impact from the TGF beta. So this is the waterfall graph showing 4 different dose levels on the blue, green, brown, and the pink one. The pink one represents the highest dose level at dose level 4. You can see overall response rate is 56%. At the higher dose, the dose level 4, the response rate is up to 75%. And the disease control rate is 91% overall. So very impressive data for a phase 1 trial. You can see this response tend to be durable. With the 9 months follow-up, the duration of response is 7.36 months. So very impressive data for phase 1. So that's for CAR T. Let's take a look at some new data in the TILs. Just in the ASCO 2025, there's a data presented for GT101 autologous TIL therapy in metastatic cervical cancer. There are about 11 patients presented. Overall response rate is 45%. With a 9% CR and a 36% PR rate. Overall, the disease control rate is 90.9%. Also in ASCO 2025, there's another phase one study using TIL in the advanced liver cancer. Although there are only two cases, but you can see the overall response rate is 50% with disease control 100%. Still very a premature result. We need to see more cases. So these slides just summarize some landmark approvals. The TIL therapy, the FDA already approved the lifileucel for unresected or metastatic melanoma with a response rate of 31.5%. The TCR-T therapy, the FDA approved the afinitrasgene autocell for synovial sarcoma with overall response rate 39%. There's some phase one and phase two trial data in solid tumor, including the TCR approach for synovial sarcoma with different targets. The response rate is in the 40 to 50% range. For CAR T cell targeting GI malignancy using Claudin 18.2, there's another trial showing the response rate in the almost 40%. With the GD2 target for neuroblastoma, there's a trial showing the response rate in the 63%. So, overall, with the full potential cell therapy, we still need to overcome a lot of hurdles. The first one is the antigen escape, especially with the solid tumor. There's antigen heterogeneity we have to overcome because the tumor can stop expressing the target and escape from the target therapy. Second is the immunosuppressive tumor microenvironment. The tumor microenvironment can release signals that turn off or exhaust the infused cells. The third one is how to infiltrate the solid tumor, because physical and chemical barrier prevent therapeutic cells from reaching the site and from penetrating the whole tumor. The fourth one is limited cell persistence, because the cell you infuse can become exhausted and it can be eliminated by the tumor. So how to keep the persistent efficacy is a challenge. Also, the manufacturer complexity is also a barrier. With the autologous therapy, they're so complicated. It's time consuming. It can fail if the patient's cells are not good anymore, because a lot of patients already received multiple lines of therapy. Their immune system is already weakened. So the quality of the autologous cells are not good anymore. So there's a trend to push the harvesting the immune cells as early as possible in the